And I'm always glad to have the opportunity to inform people about trauma and how it relates to kids in the justice system. That's a tremendous passion of mine. And so when I have the opportunity to come and to do training, and especially with people who are actually interested, because when I first developed the training, it was for people that weren't too interested, the juvenile correctional officers in the facilities, who I spent most of the day telling them what they were not allowed to do. So this is a tremendous opportunity for me. So welcome. So today I'm going to be talking a little bit about trauma, kind of defining trauma. And I know that you've had presentations on trauma previously. So we're not going to talk about the brain and the amygdala and all those things today, even though those are really important. We're going to talk about the application and why. So why? Why does that matter? How does it impact these young people? And what does it mean in terms of what you need to think about in terms of engaging them and engaging their families? So we're going to do some conversations, we'll do a little work in terms of talking about that this afternoon, and we're going to do a little bit of presentation this morning about that. So I want you to remember all the things that you've learned and think about how they apply when we review this curriculum. So to tell you just a little bit about myself, I am a child psychologist, and I studied at The Ohio State University before it was The Ohio State University. And there I had the opportunity to work with children and adolescents, and that's really been my passion. I think since I was a young child, even myself, when I was probably 15, I started working at shelters for kids who ran away. I didn't exactly know what I would be doing in my life related to that, but that was a passion of mine. And so it gave me some insight into what these kids are like, that they're not just bad kids. Some of them were much like myself in many ways, but just had additional challenges. And so that's kind of my perspective in working with young people. So as soon as I got my license, as I was sitting there for my, getting ready to pass my exam, or at least I assume I passed, because they actually didn't tell me I passed my exam before they asked me, did I have a job? And I said, well, that's really dependent on me passing this exam. So they said, oh, well, you passed the exam, but juvenile corrections is hiring. And I thought, wow, what is juvenile corrections? And so they said, working in the facilities with young people. I said, oh, that sounds exactly what I'd want to do. So that was my start. So as soon as I got my license, I started working in Ohio's juvenile correctional facilities as a staff psychologist. Did that walked in the door, and those of you that work in juvenile corrections will understand this. Walked in the door, spent some time talking to the corrections officers and everything. They're like, Doc, why did you take this job? And I said, oh, I really love working with kids, and I enjoy working in facilities, and I think it'll be a great opportunity. And they said, no, because we're closing. And I thought, oh, well, they didn't mention that part at the interview. So they told me kind of the deal about what's happening, which is why I have a great respect for JCOs and youth leaders and others. So that they gave me a little hint that I might be a short-term position. But after about 9 months, which is also true of juvenile corrections, after 9 months and just freshly licensed, I became the psychology supervisor and moved to a facility about 45 minutes away to open their intensive mental health program. And at the same time, they wanted to open this other program that they called a Supermax, essentially. That was their goal. So this is where they're going to put the violent, mentally ill young people, and they wanted me to design the program. So I said, let me see, the scope of practice, liability, lawsuit. So we did not develop that program because I had a tremendous difficulty with the construct. So instead, we developed an intensive mental health program that was designed for young people that unfortunately were a part of the juvenile correctional facility. So that was kind of my experience. Did that for about 5 years. They gave me a little bit more time to get adjusted before I became Deputy Director of Treatment and Rehab Services for the state's facilities. So then I was responsible for medical, mental health, social services, education, sex offender services, and food service. And physical, recreation. So anything that wasn't specifically security was my responsibility. So I thought, this is so great. But then I realized that to have any impact, you also have to have security. So I did that for several years, and it was in that position that I really had the opportunity to look at how trauma impacts young people. Because in an administrative position, it was impacting my budget. So we talked about what would be necessary in order to develop a more trauma-informed system. And I could be that cheerleader, which we'll talk about the importance of having that cheerleader on your team. But I was a cheerleader that also held the budget and held the capacity to bring people together. So that gave me some opportunities. And I'm going to talk more about that later. So that gives you a little bit of background about me and kind of my interest in this particular area. Well, there's a study that was done in Atlanta by Kingrey, I think it was, 2010, that found that actually kids who were neglected had a higher rate of recidivism than kids who weren't. Now, for a juvenile justice professional, that makes a lot of sense to me, because what's the biggest reason why kids come back from a corrections perspective? Failure to supervise. So you say parents are failed to supervise their kids, and that fits really clearly with neglect for me. So that when we think about those constructs, that becomes an important piece. We were looking at an agency who was working on being more trauma-informed. They had a young person come in for therapy. There was a child, and talking about hatred of the police. And it was about their mother, I think, had been shot, and the response time was significant for the police, ambulance, and the ambulance wasn't showing up till the police showed up. So to show up, and he was really struggling with that. And so the police department at that point came into the community, and the chief was able to explain at that point, not saying it's a good thing, but to that young person, well, I had an officer here, and this is what this officer was doing. This officer was over here dealing with this situation, to be able to demonstrate that the response time was related specifically to how many officers he had on the street, where they were at the time, and why it took that time for them to get there. And he apologized. So you're right. I think it becomes an issue, and that's where you say systems have to respond. So some of the issues that we see in kids in juvenile justice are all the things we've talked about. Abandonment, neglect, domestic violence, all those things are relevant. But I also don't want you to forget what we consider the more typical traumas, that these kids are also affected by chronic illness. They also are in car accidents. So they have all these other things. They can be a natural disaster. So we responded to Katrina. These were kids who, the detention centers in Katrina, the kids talked about that being the most traumatic thing that they had ever experienced, even though they were incarcerated, was, not being able to get out, figuring out where they were going to go. The flood became the issue for them. So recognizing that when you do screenings or when you're thinking about gathering data, that you not just capture what I call, and I'm going to say this in the sexy traumas, the violence, the other things, but that you also make sure that you're encompassing the traumas that sometimes are unseen in these young people because they just don't look like they're as valuable related to their overall experience. So how many of you learned about fight, flee, or freeze? To either as a function of this or Psych 101, okay? So I'd ask you, why do you fight? Why do you flee, or why do you freeze? What makes the difference? How do you know? Your desire to survive is it, so that the goal, which I think is really important to remember, and it's going to be really important when you think about intervention, the goal is to protect. I don't care anything else you want to think about, the goal is to protect, okay? One of my mentors, Bob Pioneers, who I also co-trained with at the network, has helped me to recognize, okay, this, because he asked me a question, I felt so dumb, I don't know why they choose to do what. But part of it is if you think about the construct of protection. So the body, what happens in the body is the hypothalamus will turn on, okay? Tells your body that it's time for it to respond. You're going to have this release of adrenaline and cortisol, which are all the hormones you need to respond. They get your body all kind of juiced up and prepared. They're also stress hormones. Your heart rate, blood pressure increase, breathing rate increases, you're less sensitive to pain, your body is more capable of healing itself, lots of things happen in this entire process. And then finally the hippocampus, in a very simplistic way, is your recorder. So records elements of this for future to help you make decisions. So when I talk about these three things, I say not only is it the actual experience, but it's your perception of the experience. It includes developmental level or age, your cultural background. All of those things play into what you do, okay? And I'm going to give you this example. So I married my husband. He's a wonderful man. He is from an area or community in Ohio called Youngstown, Ohio, which is like, used to be known as like the murder capital of the world. So to think about it, it's a community, the steel mill's shut down, every other house is vacant. It's not necessarily the safest community in the world. He grew up in that community. I grew up in Columbus, Ohio, which in an area that I would consider an inner city suburb, however I want to describe it. It's a part of Columbus where, you know, I generally take the perspective that most people were safe, that you could approach people, trust people, like people. I loved meeting people. That was my personality. I had what we will call the just world perspective, that generally speaking, the world is a just place. Police respond. People do what they need to do to take care of me. He, on the other hand, had a different upbringing. His upbringing led him to behave a little strange to the psychologist. So I thought he was a little on the paranoid side, because when I met him, his perspective was, hello, I'm sure you're going to hurt me. You prove me wrong. That's his perspective. His perspective was, demonstrate to me that you're safe. No assumptions of safety, or that you have my best interest at heart. And he approaches life that way. So we go into school systems. I feel really sorry for my kids who are in special ed, because he knows this much about special ed, but he's about this big and forceful around the issue of making sure that his kids get what they need, because he doesn't trust that they have our kids' best interests at heart. So that's his general perspective. So I meet him. He decides after a couple weeks it would be a good idea for me to go visit his family. And I'm excited. I'm thinking this is a great thing. So we go to Youngstown to visit his family, arrive, and you won't know it from me drinking water because I'm trying to rehabilitate myself, but I am a caffeine addict. And so we arrive, and there's like this McDonald's I see down the street. And his grandmother says, you know, I said, well, I really want some coffee. So, baby, I got some coffee. She pulled that orange cap stuff out and stirred that in there. I was real polite, but I was like, this is not going to cut it. So I had looked, and I said, well, you know what? There's a McDonald's down the street, and I'm just going to walk down and get some. And he looked like he just spun around. He said, you're not going anywhere. And I thought, oh, no, people tell me what to do, especially you. You just met me. But I listened for a couple minutes, and the next thing he said was, my grandmother will go with you. I said, your grand, what? I don't understand. But what he was saying was, you're gullible. You can't walk from here to there safely and return because you're not wired for this community. And he knew that about me. And so he sent his grandmother that even though she's 70, she's wired for the community and she's packed for the community. So she's equipped to get down the street. And so the construct kind of, when you think about responses, and you now think about fight, flee, or freeze. Now let's say, because we're back in our community, and say somebody breaks into our home. What do you think my response is going to be? From under the bed with the phone and my kids, yes. What do you think his response is going to be? He's going to grab his piece and he's going to move in the direction of the intruder, okay? His response is to protect, right? But see, I know that me going toward an intruder is not going to protect anybody, but him going, in his mind, he has the capacity to protect. Our responses are totally different, but they are both designed to protect. So you just have to understand that what happens, what you do looks very different. When you think about behaviors and reactions, I want you to keep this in mind, that there's a goal for every behavior. And so when you think about trauma, people say, oh, you fight, flee, or freeze. And it's kind of like, oh, no, you don't. There's purpose. And there's predictable purpose when you really look at and understand the young person's experience. You do have to consider developmental factors. So what a 3-year-old does, a 9-year-old does. And then I want you to envision now my 16-year-old young men very different. Domestic violence in the home, 3-year-old may run to somebody that they think can protect them. 6, 7-year-old might decide to hide under the bed. If they're really perceptive, they might call the police, but they also may decide, I'm just going to hide because I'm not going to expose my family to that. 16-year-old says, oh, no, not today, boy. And he's in the middle of it. So then you have a response that actually gets him moving in the direction of contact, okay? So what is a potentially traumatic event? So DSM-5 has had some minor changes, some of which I like, some of which I don't like. But it's the experience of exposure to actual or threatened death, serious injury, or sexual violation, and the individual experiences it directly, witnesses it, hears about the violent death of a person that they love, or is there responding to an incident or is responsible for the aftermath of incidents. So these are the people when I think about workers. So I think about corrections staff, probation staff, I think about the social workers and others that work with these kids that hear these stories and have direct exposure to their traumas, okay? So when we think about traumas, we think about the 4 characteristic criteria variables. So once you've experienced a trauma, you may or may not go on to experience the trauma response. And when we talk later in the day about screening, that's going to be critically important because you're going to have some kids who experience a trauma that may not have a trauma response and some that do. So the responses we're talking about are intrusion, avoidance, and I'm going to talk about these more. So negative alterations in cognition and mood, hyperarousal, reactivity. Those are the potential trauma responses. So intrusion. So intrusion is when things intrude into your consciousness. That's a response, and that's what this one is. So those are images, sensations, feelings. Those come into your consciousness, and you are unable to avoid them. So they're uncontrollable. So those include the traditional things you think about, like flashbacks, okay? But it also includes other things like nightmares, okay? Just a thought popping into your brain, okay? All the way to the more dissociative flashback response. They also include physiological responses. So sometimes you begin to have a sensation in your body that actually is a trauma response, but it's also a reminder of the trauma. So all of a sudden your heart is racing. That's an intrusion, okay? All of a sudden you're having some problems with your headaches, which you will see young women, particularly when you look at trauma response. A big red flag for young women is unexplained physiological issues. It happens with boys too, but we're beginning to see that tends to be a more common issue in girls. Intense or prolonged psychological distress, so you just can't seem to control your level of distress. So let's take a look at what this looks like in a young person, or could look like. So this is Kari, and Kari is actually, I made up the name, but he's a participant in a program that I'm going to talk about later for young men who've been shot, stabbed, injured in other ways. So he's participating in the program, and he's talking about his intrusive thoughts. So he says, he's a young man who was shot by a robber who stole his gold chain. Of the assailant, he says, I can't get this dude out of my head. I see him every day, every night I see this dude, and he's locked up. That's an intrusive thought. Now, where does that intrusive thought go? So revenge is often begins with this intrusive, ruminating thought that you can't get out of your head. So it's a piece that when we talk about prevention or working with these kids, you've got to address, and later I'm going to talk about it more, you've got to address revenge. Because you can't sweep that in, oh, baby, you don't really want to hurt him. Yes, I do. I do want to hurt him, and I want to blow up all his family, okay? And there's a purpose to that, too, around protection, at least in their mind, right? So this is an intrusive thought. So you want to think about where intrusion can go. The other is avoidance symptoms. So avoidance symptoms come in 2 different pieces. The first part of an avoidance is avoidance of internal reminders. So those are things that you may not necessarily see, but they include things like your thoughts, So sometimes we try to avoid thoughts. We don't want to think about something, so we do other things to avoid thinking about it. Feelings, physical sensations. Now, one of the things that I want you to think about is some of these kids have had tremendous trauma at the hands of their caregivers, right? Or people that were entrusted to care for them, okay? Or, well, we'll leave it at that. So these are people that at one time they had a sense of maybe love and affection and connection. Maybe. What do you think happens when you remove that child from their home and you say, you know, that things aren't going so well at this home, but then you place them over in foster system, in a foster home, and then the new people are like, baby, I'm going to take care of you. It's going to be all right. You're safe. Things are going to go well. They begin to develop a connection with this family. What happens next? Huh?
7-day notice.
7-day notice. Come get him. Well, that's all partially about that becomes a heavy reminder of the fact that the last person or the family that I had that told me those things and provided that sense of support eventually hurt me. So you recognize that this becomes, therapists see this all the time. You work, you got a good connection, you think you're doing well. I'm so glad that the client finally, they went from this, I'm not telling you shit, to showing up and working with you, and you're thinking, oh, I'm gonna come see you, I'm gonna, at your game, support you. The next thing you know, they stop showing up, they don't want anything to do with you, and some of it has to do with I'm gonna get rid of you before you get rid of me, okay? So the other piece is avoidance of external reminders, people, places, objects, activities, and situations, and those are just more direct. So places that remind them of the traumatic event they may choose to avoid. Right? And if you think about that for a while, avoidance can't always be physical avoidance. And so sometimes they're avoiding kind of with their mask, because I can't avoid the community where that happened. I can't necessarily avoid the person in the same way. So they may have multiple other ways of engaging in avoidance, okay? So the next one we think about is this alterations in arousal and reactivity. One of the things I do like about the DSM is that they have integrated irritability and aggressive behavior. In the early curriculum I developed, I had a whole other slide about this is about trauma, and this is how trauma looks in kids who are in contact with the JJ system, because they weren't really ready to recognize that these kids are irritable, aggressive, and that is a part of their trauma histories. They also engage in self-destructive and reckless behavior. And when you think about it, once you shut down and you don't have emotion, and you teach yourself to kind of function at this level of emotionlessness, you don't have the same issue with danger anymore. So in a similar way, you're more likely to approach it, you're more likely to engage in it, which means that they're more likely to do things that appear to most people as relatively reckless, okay? Young children, we see, you walk in the clinic, the young child is up on top of the table, jumping off stuff, things that you go, that's dangerous, okay? And you know that there's an issue because this is the same parent who's just like this kid. You're the one going over saying, sweetheart, I'm gonna need you to get off this table, on the feet on the floor, butt in the chair, because parent is oblivious to this, okay? So these kids also have concentration difficulties, which you can imagine affects them in so many areas. They also have sleep disturbances, and if you want to think about anything that impacts the life of these kids more, it's sleep disturbances. So if you don't get a good night's sleep, if you're not sleeping regularly, if you're not sleeping on the appropriate cycle for the structure of your life, then you're probably not functioning well in many areas of your life. And so sleep disturbance becomes big. When we look at kids that come into our facilities, that's like the biggest issue. They don't go to sleep. The officer goes, he didn't sleep at night. He's up all night long. And so we have to talk about things like, and then the teacher comes and tells me, what do you think the teacher tells me? He's sleeping in class, okay? It's like, you got him, he doesn't sleep at night, but he's sleeping in class. not until I really did trauma work did I begin to understand that part of that was that was a safe place to sleep because I wasn't going to get stole on in class. All right. But at night, I might get stolen. So I'm going to stay awake. And so this concept that, and the other thing is that some kids have difficulty because you can fall asleep in class and there's this sleep, wake, sleep, wake, sleep, wake. Deep sleep for some kids gets into nightmares. And so they want to avoid the nightmares so you don't sleep at night. So thinking about sleep disturbance, it has a whole lot of things to think about when you think about medication for these kids. These kids are often medicated for sleep. But when you think about medication for sleep, it's so important to think about not just medication for sleep, but there actually are medications that can assist and target the symptoms of trauma that help with relieving the actual nightmare so that you're capable of getting a restful sleep. So, all right. So the next one we think about is negative alterations in cognitions and mood. And basically what I want to be able to point out here is that when I did do whatever juvenile justice work, we always focused on this thing called criminogenic thinking patterns, right? Normative peer culture, minimizing. And we worked really hard to let kids know that their thoughts were wrong and that they needed to change those thoughts to the socially appropriate thoughts, right? So now that I'm doing trauma work, I like the construct that kids have thoughts. Thoughts serve a purpose. But that in many senses, these kids have persistence, distorted, if you want to call it, blame of others. Some have blame of self. They have a distorted view in many ways. And when you say distorted, I don't even like the term distorted because the view that they have was built in the soup of the trauma of the lives that they've lived. And so it only seems distorted to people that haven't lived their lives. And so sometimes I think we need like JJ professional mental health thinking pattern training because we have to have some understanding about how those beliefs develop. Yes, it does put them at greater risk, but there's a difference between saying your thought is a bad thought and saying I understand where your thought came from. It still puts you at risk. Let's figure out if we can help with that. Either I need to do something, community needs to do something, we need to do something to help with that thought. But it's not uncommon. I'm not telling you that these kids have very negative views of the world, negative views of whether or not things are going to work out, don't have a real sense of the future in the same way that we might want them to. And if you don't have a sense of the future, it sure does impact things about like whether or not I'm going to study for the GED, whether I even give a darn when it comes up, whether or not I'm even going to come to school. So those pieces, until you get them seeing a future, and when we do our therapy work, it's like steps. I want you to see to next year. Do we have a plan for next year? Yes, we actually have a plan for next year. Thank you. I don't start talking about college and other things. We talk about next year. First we talk about next week, then we work on next year. So that becomes a piece when you think about their cognitions and mood. So as I had mentioned, we're going to focus on thoughts. How many people have heard of the invisible suitcase? If you do the child welfare curriculum, they have this invisible suitcase. But the invisible suitcase is really the group of thoughts that the young people and all of us have that guide the way we interact with others and behave in the world. So they're your views about self, others, and the world. Okay? Kids that have these backgrounds have this suitcase. It's invisible because you don't see it, but it sure does guide their interactions with you. And it's often impacted by trauma. So this suitcase for these kids might say, it's all my fault, I'm bad, grown-ups lie, I'm stupid, you're going to hurt me, no one loves me. Get them before they get you, you're paid to care, I'm no sucker. Okay? Those last three I add for this type of training because in addition to worry about people are going to hurt me, they also think about, I'm going to get you. It's also a part of that because they don't have a sense of belief that others are actually genuinely concerned about their well-being. So we talked about numbing, and I'm going to play a little clip also from a young person that's in a program that deals with kids who have experienced trauma, intrusive injuries.
So a lot of things that made me scared or made me nervous, they don't scare me no more. They don't affect me. Like, if a whole bunch of dudes kept on looking at me, I used to feel nervous. And if someone would come on, giving me mean looks, I used to get nervous. Don't happen no more. It don't happen. It's like some of the feelings just gone. If they look at me mean now, I'll look at them like that. Like, like they just took some emotions that I used to have, that nervous feeling, that scared, just gone. It's not even with me no more. I don't even know what it is, but it's not.
Okay. So what do you think about that when you lose nervousness and fear, which is a numbing response related to trauma? How do you think that affects a young person? Behavior. You almost expect it. It's just the way it becomes a way life is. So it's not, to me, it's shocking. To most of the young people there, it's not too shocking. But yeah, it's kind of like I tell people, how many of you guys like pain? Like really enjoy pain, appreciate pain? Okay. Not many of us would say we do. But what would happen if we lost the feeling in our toes? What would we do? You start knocking them into stuff, like people who have problems with sugar. That's not the right term, but in my community we call it sugar. They got sugar problems. So, so let's say that they have that, and you bump your toes. Eventually, they got to cut them off because you don't have a perception that you've injured yourself. And so I tell young people that you injure yourself every day, but because you're so numb, you don't even know it. And in addition to that, that numb place does protect you in your mind. It keeps you from experiencing the pain of some things, but at the same time, you don't experience the pleasure of things either, because numbing is not selective. So you're going to lose joy. And so when you talk about these kids, when you work with them, experiencing joy is a work. Experiencing pleasure, comfort, calm is something that you work with them on, because it may not be something that they understand. So asking the question, what do you enjoy doing? I don't know. Some of them really don't know. So that becomes a piece that you work on. So this is my definition of coping. So a coping strategy is a behavior individuals use consciously or unconsciously to tolerate adversity, disadvantage, or disability without correcting or eliminating the underlying condition. So do you agree with this general definition of coping? Okay. You can't change the trauma that happened, the negative things. You're just trying to manage them. Okay? But in terms of coping, what are some of the things? You guys are professionals, you have stressful lives. What do you do to cope? You exercise? Okay. Huh? Somebody drinks water? Lots of water. I knew that you guys needed this afternoon, this evening, when he said there may be adult beverages. Some of you said, I'm staying. Okay, what else? Exercise helps physiologically. It helps a lot. So lots of good and different coping strategies that we'll talk about. So I want you to take a moment, and I'm going to remind you to take good care of yourself. I want you to think about if this were what you were coping with, what strategies would you use? And I want you to remember, when you develop coping strategies, you want to think about, whether it's you or the young people you deal with, you want to think about a strategy that's going to increase your sense of physical and emotional safety, because that's always our goal, decrease anxiety and fear, and maybe protect you from the impact of future traumas. I have a young lady I helped that she got an apartment by the skin of her teeth with her 2 kids. It was great. I helped her a little bit. She then called me about a month later. She had left stove on, apartment burned down. And so now, of course, she didn't think that she needed insurance, so I had mentioned that multiple times, because in my world, gaining someplace to live involves gaining insurance. But in her world, that was like after other things. And so now she's incapable. Nobody will rent to her because she's still being sued. by the apartment complex for the other pieces. So you think about that's a different, the response is different. So just to kind of move along, when you think about this particular one, I said, well, what do our kids do? Okay. And a lot of times, many of our programs have wonderful strategies for stress reduction, regulation, those sorts of things. But unless you build in the part to help understand how that relates to the experiences of these young people, they're not effective. So me saying we're going to envision the beach may not necessarily help this child at this point. So you have to think about what your methods are. So when you think, I want you to think about a young person who by themselves has to come up with a coping mechanism without much instruction, support, or supervision. When you think about coping, though, these kids, think about they're developing them on their own. And developmentally, it makes a difference in terms of what they select. So I'm talking about my adolescents and what they select. So they're going to use drugs. They're going to join gangs. That helps them to feel somewhat safe, protected. You think about the little cliques. Those weren't gangs, but the little cliques were their communities of safety. Some of them eat. That becomes a way of coping. Some of them engage in sexual activity for lots of reasons. I didn't have time to talk about development and the necessity of connection and relationship and attachment, but that's a necessity for all of us. I don't care how big, bad, whatever you are, unless you're truly psychopathic, we all desire to have connection. And so some of our young people interpret that as a sexual relationship, okay? And so they will engage in multiple sexual relationships, in addition to the physiological response of the body to sex, which creates stress reduction. It creates calm for most of us. So then there's carrying a weapon, smoking, which I don't know what Dr. Nadine talked about, but smoking marijuana has a natural effect on the body that helps to calm. It also decreases nightmares. It's a very wonderful drug for that purpose when you used within a realm. So when I think about probation, as strange as it may sound, I talk about urine drops and the necessity of being careful about when you revoke based on that, based upon what resources and tools have you provided, and or is it reducing? Is there times or periods of stress where it may be increased? And so you kind of have to work with the kid around reduction of something like potentially marijuana. So focusing then on kids that hit walls. I never understood why kids hit walls. Trees. I said, well, it's better than hitting a person. That's true. I prefer you hit that wall than me. And then in the middle. So is suicide a coping strategy? Does it reduce stress? Does it decrease the likelihood you'll be hurt again? Okay. It's a coping strategy, permanent one. But just like we have to ask kids about revenge, we have to ask kids about the reality of suicide, because these kids also, in addition to being injured in other ways by each other, they also commit suicide. And some of them commit suicide by getting injured by others, okay? So I asked you before, is revenge a coping strategy? And I'm just going to say yes, because we've talked about that. And it's based on this concept called the social contract. So how many people have heard of the social contract? Okay. Social contract says what? That we'll take care of each other. Police are going to respond. Parents take care of their kids. There's this just world that is designed for us to keep everyone safe, okay? So there's this social contract. How many of your kids believe in the social contract? Not too many. I'll help you. They have no belief in the social contract because it has not been applied to them. They may or may not have been asked to in some ways sign it, but the other signees have not held up on their agreement. And so revenge becomes a way of coping, because if I can erase you, we think long term, but if I get rid of you, then maybe I've increased my ability to survive because you aren't going to hurt me. In addition to that, I've increased my capital in my community. So maybe you won't bother, the next person won't bother me either because they know I'm big and bad, and that's a piece that helps me to feel protected. Now we know that in the reality of things, that's not. But for the moment and overall, revenge is viewed as a coping strategy. Okay. So I mentioned that these kids have difficulty. So one of the things I want you to remember, we did a study, or there was a study that was done that looked at the pathways to recurrent trauma among black men. And in that study, they found that 65% of the participants said they do not have faith in the police. I don't think that's probably a big new sign for you all, but that becomes important, that they're almost the last people they're going to call. So this is an example of one of the other participants who said, the one that did it, the police didn't ever catch him. I doubt they were ever looking, the police. No, they ain't doing their job. I don't think they're doing their job. And so when you come with that perspective that the police are unavailable to you, that the arm of society that's supposed to protect you is not going to, then you do think of strategies that involve taking things into your own hands. So I'm not going to go into this in depth because I know you guys have talked about this. How many people have heard of the ACEs study? Adverse Childhood Experiences Study? Good. So basically, in a nutshell, you guys have Folletti from Kaiser Permanente and Dr. Anda. But does anybody remember what Folletti was studying? Adults. And what was he studying about adults?
Diabetes, heart disease, hypertension, stroke.
Well, those are the things that happen to them. But what was his study initially about?
Childhood stress, what levels of stress they experience in children that are having an impact on their medical well-being as adults.
That is the end product of his study. So what he was actually studying was obesity. His whole study, he didn't start out looking for adverse childhood experiences. He's known for that, but he was really working with morbidly obese people, like 450 and more, okay? And so he was working with them on losing weight. And what he determined was he would have these superstars that would lose all this weight, get down to a healthy weight, and then disappear. Or they would lose a bunch of weight, and then they would gain even more, okay? And so as any researcher say, well, my methodology's working well, what is my failure rate about? And what he found out was that his failure rate was about kids, young people, was about adults who, when they came into his office, would say, he'd ask, well, when did you start gaining weight? Oh, when I was molested, when my father left, when we lost our house. And so he said, he checked with one, he said, okay. Then he asked the next one. It was some other adverse childhood experience. So after about 5 or 6, he started talking around the country about this relationship between obesity and adverse childhood experiences. And that's when he hooked up with Dr. Anda from the Centers for Disease Control, and then they studied it in a more succinct way to see what happened with well people with insurance, predominantly Caucasian, who over a period of time, who have adverse childhood experiences. And that's when they discovered that people who have multiple or more than 4 or whatever, as your ACE score increases, so does your risk of smoking and severe obesity, suicide attempts, multiple other things. But I point these out because these are the same things that our kids do. So, and I point this out to say that, and if I can say it in a kind way, Caucasian middle-class people deal with trauma just like our kids do. So we don't want to separate them out and say, we're different in some way. That actually all of us have the survival coping strategy that we resort to when we need to, okay? There's a few of us that have that bottle of wine at our home that we look forward to every evening, okay? Small steps, but it's a survival coping strategy. I'm not going to play this. This is a clip from one of the participants in his study, but I'm not going to play that one today. One of the things to think about, though, is that his ACE study did not include many of the traumas that our kids experience, like community violence, being shot at, being jumped or beaten, being stabbed, having lost someone close to you to murder. Those were not included. So if you think about an ACE, and some of you may be considering your screening instrument, ACE does not include community violence, just so you know. There are 10, and they don't include community violence. So our kids would have 10 plus because they often include all these other things that can happen to them that aren't included in that particular study. There also aren't a lot of physical injury-related issues in this particular one. So it's really more about interpersonal violence and family issues. Okay. So how many of you have heard of Dr. Rich, Dr. John Rich? I loved reading his book. So if you really want to have a better understanding of trauma in the lives of young black men, read this book, Wrong Place, Wrong Time, Trauma and Violence in the Lives of Young Black Men. It's inspirational for me. Helped me to understand many things about the kids that I work with. Helped me understand some things about my husband. He stopped being paranoid after being married to him about 9 years, and I realized where his point of view was developed, okay? And now we're able to co-raise children, even though his view of when somebody fouls you on the basketball court, you, bow them in the mouth. I'm like, okay. That is not my perspective. But his perspective is if you allow people to do things to that, they will continue to do things. So my 12-year-old said, Daddy's perspective, Daddy's always got violent solutions. And I'm like, but she's got my perspective on life. They probably just bumped into you. So that is a very important read book, because he was actually doing some studies in Boston that was looking at young men and violence, and he's a physician. And so he was doing some research looking at kids as they come through the emergency room with penetrating injuries. And what he was finding was that if you were to come into the emergency department with a penetrating injury, there's a 44% chance that you're going to turn in 5 years and a 20% chance you return dead. So he was really looking at how do we stop violence. And I'm going to show one more, and I'm going to stop for today, but for this part. But part of his study really looked at not just the kids, but also our systems and how they approach the kids. So this is what he found. So he said, well, youth comes in, and these are black and brown kids, shot, stabbed, or assaulted to the emergency department. They're treated in the emergency department, admitted maybe to the inpatient surgical service if they need to be, and they're discharged to the street. How do you like that circle so far? Anything missing in the circle? Maybe mental health support, explanation of just what just happened to you, So the other thing, if you read his book, it's interesting because he'll say the first thing that he confronted was, so what do you think the nurse that took that young person in first thought about that young person? Huh? Something happened. He deserved it. He's bad. You might want to think about it this way. How did he get himself shot? So you did something. And we need to think that way, right? Because if we don't think that way, we could get shot, right? But if we think people do things that get them shot, then I don't have to worry because I'm not going to do anything to get myself shot. So it's a perspective. But if you start with that perspective that he's a gangbanger, he did something to get himself shot, your care of that individual is different. Your engagement with their family is different. And in reality, it doesn't matter. They're a victim at this point. They've been shot, okay? So they get discharged to the street. He learned, because he had been working with Sandra Bloom, that these kids often had adverse childhood experiences prior to this whole incident happening. And so it increases their likelihood of having acute PTSD symptoms. So now they're hypervigilant, anxious, probably in pain, because the other thing is, if you get yourself shot and you come to the emergency room and then you get discharged, do you think that the doctor is ecstatic about giving you pain medicine? No. So they're under-medicated, either because it wasn't prescribed or they didn't have the insurance to fill it. And so they leave. They have that, so what do? I'm going to protect myself, right? So if they didn't have one before, they might get a weapon. They might begin to self-medicate, okay, with things they can access. So in that hypervigilant, self-medicated, revengeful place it's not uncommon that they would retaliate, re-injure themselves or someone else, leading to death, detention, and the cycle continues. So when you look at violence and the cycle of violence from a trauma perspective, you recognize that you have the capacity to intervene with trauma-focused approaches. And so, I will talk about it today, but he has an entire program that was developed along with Sandra Bloom and others called Healing Hurt People, which is why some of the examples I use with young people are part of that. So it's a hospital-based intervention program that includes social workers and others, starting with when they come in, they said, you know what, when you leave, you're going to be hypervigilant. These things may happen. Do you need help getting pain medication? By the way, were you in school? Do you need help maybe re-engaging with school? So it becomes they call it a golden moment. When you get shot, it's a golden moment of intervention, an opportunity to connect them with resources and reconnect them to the community. So, as I said, I am not going to show this clip, even though I love talking about resiliency.
Can you just back up 1 second? What's the name
Yeah.
of the program that he has? Is also maybe that golden moment time?
The program, if you look up Healing Hurt People, you will find it, and then there's a lot, like Dr. Corbin actually does it. There's one in Philadelphia at St. Christopher's Hospital for Children and Hahnemann Hospital, which is the adult hospital. Okay. All right. And I don't talk about resilience. I won't have time to show this particular clip, but it is important to think about building resilience in young people as an intervention, that it's not like just therapists and other people. When we work with line staff, we work with probation officers and others, part of their task is to connect and partner with us on building resiliency. So consider that. Thank you very much.